Hello and welcome to the topic Study Design in the module Statistics. Here we will be discussing on how to select study designs, grade of evidence in a study, randomized control trials, crossover trials, the intention to treat, what is bias, evidence and recommendation, systematic review, and graphical representation of data. Let's get started. So this table shows how a study design can be selected to match their respective research goals. If you'd like to describe disease or spectrum of a disease, you may do a case series or report or a cross-sectional study. If you are determining operating characteristics of a new diagnostic test, a cross-sectional study is appropriate. To describe prognosis, a cohort study can be done. To determine cause and effect, a cohort study and case control study can be done. To compare new interventions, a randomized control clinical trial is the most appropriate study. And to summarize literature, a meta-analysis is done. This table shows the features of various study types and their key features. For randomized control trial, participants randomly are allocated to intervention or control group. Practical and ethical problems may limit the use of this trial. For cohort studies, it is an observational and prospective study, and the usual outcome is a relative risk. For example, the Framingham Heart Study. A case control study is an observational study and it's seen retrospectively. The usual outcome measure is the odds ratio, and this is prone to confounding. Next is the cross-sectional survey. It provides a snapshot, sometimes called a prevalence study. It provides weak evidence of cause and effect. This pyramid in the slide shows the equality of evidence or grade of evidence of each study design. Systematic reviews have the highest quality of evidence and expert opinion has the least, hence would be deemed the weakest. What is randomized control trial? It is the gold standard for evaluating new interventions. The purpose of randomization is to prevent systematic differences between treatment groups. Classical errors that occur in randomization include consecutive sampling, which may well not be representative in the study time if the study time is short, convenience sampling, where there's strong potential for bias with volunteers generally healthier than others, judgmental sampling, including those that you want only, and the potential for systematic error is enormous. And in randomized control trial, the results best summarized as mean and confidence interval for the difference between the active intervention group and the control that is of importance. A crossover trial. The principle of a crossover design is that a patient has one drug or treatment and then a washout period, and then another drug, and the effect is compared between the two in a single individual. For this reason, it is a good study design for treatment of chronic conditions, such as comparing analgesics in arthritis, but it's not appropriate for acute conditions. In a crossover trial, the patient, who usually has a chronic stable disease, receives one drug or placebo and then the other drug after a washout period. Each patient will only usually receive all drugs within the study. In this way, confounding can be greatly reduced. If treatment is a disease modifier, parallel trial will be better than a crossover trial. Intention to treat analysis. Intention to treat analysis is a method of analysis for randomized control trials in which all patients are randomly assigned to one of the treatments and are analyzed together regardless of whether or not they are completed or received that treatment. These include the patients who drop out in the final data set. Intention to treat analysis is done to avoid the effects of crossover and dropouts, which may affect the randomization to the treatment groups. Intention to treat helps to reduce bias by sticking to the original allocation of treatment and analyzing the patient in that treatment group even if they do not receive the treatment. Bias. Bias occurs when there is a systematic difference between the results from a randomized controlled trial and the true state of affairs. A selection bias occurs when the study population is different from the population to whom the results will be applied and there is therefore said to be. Allocation bias occurs when patients are not randomly assigned to a particular treatment. Assessment bias is when the observer knows which treatment the subject is taking. Observer bias is when one observer consistently under or over-reports a particular variable. And lastly, a recall bias applies to case-controlled studies when a patient is more likely to remember a particular detail of exposure if they go on to develop the disease. Let's look at study design, evidence and recommendations. These are the levels of evidence. 1A is evidence from meta-analysis of randomized controlled trials. 1B is evidence from at least one randomized controlled trial. 2A is evidence from at least one well-designed controlled trial which is not randomized. And 2B is evidence from at least one well-designed experimental trial. Level 3 is evidence from a case, correlation and comparative studies. And level 4 is evidence from a panel of experts. So this is then put together and we can decide the grading of recommendation. Grade A is based on evidence from at least one randomized controlled trial, which is level 1A or 1B. Grade B is based on evidence from non-randomized controlled trials such as grade 2A, 2B or 3. And grade C is based on evidence from a panel of experts, which is level 4. Phases of a new drug development. So this table explains what are the phases one goes through when they are producing a new drug for treatment. The first phase is called the animal trial phase. This is done to assess safety for testing the drug in humans. Phase 1 trial is to assess initial safety, which is how the drug is metabolized and excreted and most frequent side effects. Phase 2 is to assess effectiveness of the drug. Phase 3 is to assess the effectiveness compared to commonly used treatment. Phase 4 is to assess the side effects. Systematic review or meta-analysis. This is a study of studies, where statistical or quantitative combination of results from two or more studies addressing the same research question. A meta-analysis equals to the systemic reviews plus quantitative measures and is used in treatment studies. A meta-analysis would look at combining all previous data, and this is likely to be the quickest option to complete and also produces the highest level of evidence. There might be publication bias, and this can be examined by funnel plots if a sufficient number of studies are found. This table elicits the advantages and disadvantages of three types of studies, which are the cohort, observational, and case-control study. A cohort study is able to study exposure factors that are rare, less susceptible to recall bias, and is able to measure the incidence or risk of disease. However, it seems to be time-consuming and expensive to perform. Observational study is able to investigate rare diseases. It is cheaper and easier to perform. However, it cannot infer cause and effect. A case-control study is suitable for rare diseases with wide range of risk factors can be investigated and there can be no loss to follow up. However, there can be recall bias. Lastly, we will be looking at graphical representation of data. For qualitative data, they can be represented in the form of a bar chart or a pie chart as shown. For quantitative data, it can be depicted in a histogram or a plot graph. We have come to the end of this topic. Thank you.